Good morning and welcome to the first of our California Longitudinal Data Collection for Sickle Cell Disease webinar series. I'm Faith Rader from the California Department of Public Health, and I will be serving as today's moderator. I have muted all the conference lines to eliminate background noise. After the presentations, we will allow questions. You can raise your hand during the presentation, but we'll wait until after the presenters are done for the discussion period to address those comments. Also, this session is being recorded. To begin, I'd like to introduce our two presenters. Mary Houlihan is a health scientist in the Epidemiology and Surveillance Branch of the Division of Blood Disorders in the National Center on Birth Defects and Developmental Disabilities for the Centers for Disease Control and Prevention. Over the last 6 years, she has served as Project Officer for cooperative agreements in the areas of sickle cell disease, thalassemia, hereditary hemochromatosis, and Diamond-Blackfan anemia. She was the CDC Project Officer for 2 previous projects on creating registry and surveillance systems for hemoglobinopathies, which you will hear more about later. Prior to coming to the CDC in 2008, Mary was a genetic epidemiologist at the Mayo Clinic in Jacksonville. Susan Polukonis is an epidemiologist and program director for the California Rare Disease Surveillance Program, part of the California Environmental Health Tracking Program, a partnership between the Public Health Institute and the state's Department of Public Health. Susan's work in sickle cell disease and thalassemia began in 2006 at the Children's Hospital Oakland, and eventually became a focus on the public health implications and healthcare disparities associated with rare diseases. She is principal investigator for the CDC Foundation-funded Sickle Cell Disease Longitudinal Data Collection System in California. She also conducts surveillance of other rare conditions such as ALS and the health effects of uncommon environmental exposures. So I hope we're at critical mass here, and I'm going to turn the webinar over to our first presenter, Mary Houlihan.
Thank you so much, Faith and Susan, and thank you everyone for joining today's webinar. I'm going to talk about the first couple of slides, and then I will be turning it over to Susan to give you many more details about the project that we're working on. So before she gets into everything about our longitudinal data collection system for sickle cell disease that we are in the process of developing, I'd like to give you a bit of background information about public health surveillance, why we need surveillance for sickle cell disease, the history of surveillance for sickle cell disease at CDC, and how we were able to go about starting this new longitudinal data collection system. So here in front of you on the screen, you have the CDC's definition of public health surveillance, which is the ongoing systematic collection, analysis, interpretation, and dissemination of data regarding a health-related event. And then you also have our visual interpretation of the steps of surveillance. And so as we have this up on the screen, there's a few things that I would like to emphasize to those of you on the phone today. The first is, as you can see, there really is much more to surveillance than just data collection and analysis. And really, it's the left-hand side of the circle that contains the most important parts of these activities. It's the information dissemination, the decision-making, and the action. And the whole reason we do surveillance is to make decisions that result in positive action and that are based on the evidence that the data collection and analysis provides. The second point that I would like to emphasize is that public health surveillance is ongoing. You see that the circle doesn't have a beginning and an end. It's circular. It never stops. And so once data is collected, analyzed, disseminated, and action is taken, the entire process begins again with the assessment of a new health problem. For example, if the first goal of a surveillance project is to identify patients with a particular condition, understand their geographic location, once we've completed that task, we would begin the entire process again with a focus on making sure that there are health providers in those same locations as the patients who are actually able to provide care. So there's no point in just identifying patients if we don't also take the next step to identify the doctors, nurses, and other healthcare professionals to take care of them. Next slide, please. So we know that there's a great need for public health surveillance, and especially for sickle cell disease. And there's such a great need that it's been the topic of numerous meetings and publications over the past few years. So I'm going to show you a few of those here. Here we have the 2007 American Society of Pediatric Hematology Oncology, who hosted a sickle cell summit. And the goal of that meeting was to produce recommendations that would lead to the development of a unified approach to healthcare and research disparities for sickle cell disease. And you can see here that 5 recommendations came out of the summit, including the one highlighted in red, which is the need for population-based surveillance to measure outcomes. Next slide, please. The next year, the National Institutes of Health convened a State of the Science conference on hydroxyurea treatment for sickle cell disease. And again, one of the research needs that was identified by this conference's attendees was a surveillance system for patients with sickle cell disease that contains demographic, laboratory, clinical treatment, and outcome information. Next slide, please. And then most recently, just this past year, as we all know, the National Heart, Lung, and Blood Institute released their evidence-based expert panel report on the management of sickle cell disease. And the purpose of this was to improve the care of patients with sickle cell. And so as a follow-up to that release, the authors of the report also published a summary of the research that was still needed to address the shortcomings in the available evidence. And so here, one more time, in one of the conclusion paragraphs from the paper, we see that yet again the need for sickle cell disease surveillance is emphasized in order to describe the clinical and healthcare resource utilization patterns for individuals with sickle cell disease. Next slide, please. So this idea of surveillance is not new, as you can see from these papers, and neither is the work being done on surveillance new at CDC. So really, as a direct result of the 2007 Sickle Cell Summit and the 2008 Consensus Conference, the NIH's National Heart, Lung, and Blood Institute and the CDC's Division of Blood Disorders began to develop a plan for sickle cell surveillance. So they convened a panel of experts, they met via phone calls, they had a face-to-face meeting, and as a result of that, they came up with the Registry and Surveillance System for Hemoglobinopathies project, which is more commonly referred to as RUSH. So RUSH was a 2-year project. It ran from 2010 to 2012. The funding for the project was provided by NHLBI, and then CDC administered the award and oversaw the project activities. So 7 states participated in that project: California, Florida, Georgia, Michigan, New York, North Carolina, and Pennsylvania. And the primary goal of the project was to use pre-existing data sources to identify all of the individuals in each of those states with a thalassemia or sickle cell disease diagnosis. So I have to say it was really a technically and logistically challenging project. The deeper we got into this, the more that we realized we were going into rather uncharted territories. But what made it challenging also made it really fun and made it really fulfilling. So many lessons were learned about the skill sets that each of the states really needed in order to be successful with the work. We learned about the hurdles that needed to be overcome in order to gain access to all of the data sources, and we also learned about the collaborative effort that was required. So although the state health departments were the recipients of the grants and the funding, they then worked with very large teams to accomplish all of the activities. They worked with healthcare professionals, community organizations, patient and family advisory groups, and other public health experts. And possibly even more importantly than that, the states also worked with each other and shared their experiences, both good and bad, in the collaborative effort throughout the entire project. And so if one state had a lot of success in obtaining data from a particular data source, but another state was facing a lot of challenges with that data source, they were able to work with each other, share language, share requests that they had put in to really get the most done over the time period. So after the 2 years of RUSH were complete, the Division of Blood Disorders was able to offer funding for 2 additional years of surveillance activities. But unfortunately, it was a much smaller amount of funding, and so it went to a fewer number of states. And this was called the Public Health Research, Epidemiology, and Surveillance for Hemoglobinopathies Project, or FRESH. So there were kind of 3 separate parts to the project. One is the state of Mississippi was provided with a small budget to see if they could replicate the activities of RUSH, but at a much lower cost. And so from that part of the project, we learned that reduced funding really equals reduced results. So they were extremely successful in accessing data sources in building relationships with multiple partners. But unfortunately, the amount of information that they were able to collect had to be minimized in comparison with the Rush data, and that was really a result of the lower amount of money that they had to work with on this project. So the second part of FRESH also provided funding to 2 of the original Rush states, California and Georgia, so that they could evaluate their surveillance activities and validate their data collection methods. And then the third part of the project was for those 2 states also to begin disseminating some of the findings from their data analysis. So they strengthened their partnerships with healthcare providers, with community organizations, and really tried to disseminate some information that was a result of the data that had been collected through Rush and FRESH. And so the FRESH project concluded in 2014. Next slide, please. And so here we were at the end of 2014, and then, as you may or may not know, CDC does not actually receive any congressional funding for our sickle cell work. And so we were very happy with the work that was completed in Rush and FRESH, and we knew that there was so much more work to be done for sickle cell surveillance. But unfortunately, there was no longer any money available to continue this work once those 2 projects were over. And so we had to be very creative and think about ways that we could continue funding. And the really great thing was that we were fortunate enough that this was not the end of our sickle cell surveillance programs for 3 reasons. So first, and I'm not sure if everyone on the phone is aware of this, but the CDC actually has their own foundation. Their logo is shown there on the left of your screen. So the CDC Foundation was established by Congress in 1995. It's an independent nonprofit organization, and their sole purpose is to connect CDC with private sector organizations and individuals in order to build health programs that make our world healthier and safer. So the second reason this was not the end of the road was because we're really, late last year, beginning of this year, we've really been entering into an exciting time for sickle cell research. So as you may know, for the first time ever, there are currently many new drugs and therapies that are being developed, and they're being tested by a number of pharmaceutical companies. And so these companies, as they are creating these drugs, as they are trying to build relationships with the sickle cell community, they are also interested in understanding what the health of the patient population looks like before any of their medicines are released, as well as what that health is going to look like once those medicines have been on the market for a period of time. And so they're really, again, what they're looking for, although it may not be termed that way, is sickle cell disease surveillance in order to answer those questions. And so finally, there's a lot of momentum and excitement from the Rush and FRESH projects. And this is really the third reason that these projects are able to continue. And so we realized that the foundation that was built by those 2 programs was a real change in the course of research for sickle cell disease. For the first time, we were able to identify with a fairly high level of certainty all of the individuals living in a state with sickle cell disease. So we could find those who were being seen by specialists, as well as those who did not have a medical home, and patients that really receive all of their treatment in the emergency department or in a hospital or somewhere outside of a medical home. We were also able to collect information about these individuals over an extended period of time. So a lot of what has been available in the past has been a snapshot of what the population looks like at a very specific point in time. But with our surveillance collection systems, we're really able to look at these patients over a many-year period and see what the changes are that are going inside the population. And so most importantly, there's really a lot of support for from the entire sickle cell community to see this work continue so that more information can be learned that leads to real action. So it's a combination of these 3 factors, and they kind of all came to fruition in April of 2015 when the CDC Foundation received funding from Pfizer to put together the methods, the pros and the cons learned from Rush and FRESH in order to develop a longitudinal data collection system for sickle cell disease. And then, wonderfully enough, just a few months after we received funding from Pfizer, we also learned that Biogen was willing to contribute additional money to the project, which would allow us to incorporate healthcare records in addition to data from administrative data sets. So currently the money that we've received from these two companies is enough to fund one state to begin working on this project. And we, after much consideration, we chose California for this project for a number of reasons. And I believe as Susan starts talking, these reasons are going to become more and more clear. But one of the key reasons was that they had been a part of Rush and Fresh, and so they really had the necessary infrastructure to begin this project as quickly as possible. That being said, we certainly do not have plans for stopping with just working with California. The CDC Foundation continues to try to identify additional partners so that we can bring additional states on board. And I want to assure you they're not only looking to pharmaceutical companies for this partnership, they're speaking with other industries, with private foundations, with individuals, and really just a whole host of potential partners. And so hopefully in the future, we're going to be able to share with you the good news that funding has been secured for more states. And we also hope that we do not have to rely on money from our private partners forever. While we expect that the surveillance will continue for the foreseeable future, we are also hopeful that the knowledge and benefits that result from the information learned by this data system will provide the evidence needed for CDC to receive congressional funding for our sickle cell work, not just for this data system, but for many other projects such as awareness campaigns or educational programs. And so for now, I'm going to turn you over to Susan Palyukonis, who's the California lead on this project, so that she can share with you what's been accomplished so far and what our goals are for the data collection system in the future. Susan?
Thank you very much, Mary. So California has been screening for sickle cell disease and sickle cell traits since 1990, and that allows us to identify newborns with the disease so that they can begin life-saving treatment immediately. But it's also been the starting point for public health surveillance. Here in California, the state follows up on newborns with sickle cell disease for the first 5 years of life. They began doing that in 2011, and they're doing that to make sure that that the children are seeing a pediatric hematologist and getting appropriate care. But after those first 5 years, no further follow-up is done. So we lose the surveillance capacity at that time. Another source of surveillance in the state is the data collection that's done by our many comprehensive care centers here. The centers often publish their findings, helping us to understand the impact of the disease. But the centers that we have here see few adult cases, and many of our pediatric cases don't have access to this high quality care. So this is also not a complete picture. A considerable amount of research has been done using administrative data to look at complications and healthcare utilization in sickle cell at a state level. But there have been some recent publications detailing the biases and errors in those efforts if you use only one data source, including a recent very helpful paper by Dr. Classer in California. So overall, we know very little about the care outcomes and health status of the majority of the adult population here, as well as a substantial portion of the pediatric population. Oops, sorry. Our Rush and Fresh work done through the Genetic Disease Screening Program at the state's Department of Public Health and led by Dr. Lisa Feuchtbaum really began to give us a sense of the impact of this disorder in California. For that project, we used a variety of data sources. We had confirmed cases from Children's Hospital Oakland and Children's Hospital Los Angeles, both of which see adults as well as children living with sickle cell. We also had access to all hospital discharge data, emergency room data, and vital records for the state, as well as all Medicaid claims for members with one or more sickle cell disease ICD-9 diagnosis codes in their record. We spent about a year figuring out how to link among all of these different data sources so that we could create a health status profile for people with sickle cell. And then we worked, as Mary said, with the other state and federal partners in the project to develop case definitions to determine who in our data was a confirmed case. So we had evidence that they were definitely a case from newborn screening or from the clinical setting, who among the cases that we saw in administrative data very likely had sickle cell, and who we saw with some evidence but not enough for us to include in our analyses. There are a couple of papers that are in the handout section of your webinar bar about this project and about the results for sickle cell. During the FRESH project, the Follow-Up FRESH project, we were able to further refine the case definition and also refine our data collection and linking methodology, as well as to partner with additional clinical centers and get more data on more cases in California. And in the end, we were able to identify close to 90% of the expected number of sickle cell cases in the state. And that included our confirmed cases as well as those that we felt were highly probable cases. And we counted that as a great success. I think that was better than any of us thought when we initially set out to do this. We learned a lot, as Mary went into detail about. We learned a lot about what we could do and what we couldn't do well with the resources that we had and the data we had access to. And that allows us now to move forward with confidence with this new program. So we've been busy analyzing and disseminating since the Rush and Fresh projects. A couple of highlights in addition to the papers that you have access to. As I noted, we found that even after obtaining all sickle cell cases from 5 of the largest comprehensive care centers in the state, we only had information from those sources on 20% of the expected adult population. So that really told us that we needed multiple data sources to be able to understand what was happening. So we're very close to publishing a paper in collaboration with Georgia and the CDC that explains why using death certificates alone for public health surveillance of sickle cell is not reliable and that multiple data sources are needed. And we're going to report those findings on mortality in that paper. So that paper has been accepted pending revisions, and we anticipate that it will be out in late December or early January of this year. So some initial analyses that have not yet been fleshed out or published of our data suggest that very high emergency room utilization by adults living with sickle cell in the state is seldom sustained over a long period, but is instead sporadic, which is counter to what a lot of people believe, and represents a very small number of the total number of cases. Also, some initial analyses that we're working on suggest that adults with sickle cell over the age of 45 have a markedly different healthcare utilization pattern than those younger than 45, and often appear in the data without sickle cell coding because other health conditions are more prominent, such as renal failure. And then finally, we found that 51% of our identified adult population here in the state is living in Los Angeles County, although LA County hasn't had a dedicated full service, including inpatient clinic setting for adults in the county for several years. So we know there are significant access to care issues there that need to be addressed. So with the new funding from the CDC Foundation, we've taken what we've learned from the Rush and Fresh projects, we've reorganized somewhat, and we intend to expand upon and improve our previous efforts. The work is now being done by the California Rare Disease Surveillance Program, which is part of the California Environmental Health Tracking Program, which is itself a partnership between the State Department of Public Health and the Public Health Institute. And that's a mouthful and challenging to say every time that I present, but that layered partnership and organization allows us a lot of access to staff resources, flexibility, and capacity that I think that we didn't have in the past. The key personnel working on the project right now, and this is the tracking program has a staff of 13, are, in addition to me, Paul English, who is the PI of the Environmental Health Tracking Program and co-PI for this project, Faith Rader, who you heard from earlier, who's our health educator, Jackie Valle, who is hard at work putting together a database structure for the new data coming in, Justin Howell, who will be doing information technology and data linkage oversight for the project. Eric Roberts wears a lot of different hats within the program, but will be supporting us with biostatistics expertise. And Dan Meltzer, who's already been hard at work creating some maps for us to understand where people are with sickle cell. So our plans for how to improve and expand the data system and use the data are in 3 phases. Funding, as Mary said, began in April of this year, and phase 1 is this first year, which we're a little over halfway through. We've submitted a request for IRB approval from the state and approval to use some of the data that's already been acquired, has actually already been given to us, including the hospital discharge and emergency room files. As soon as we receive IRB approval, which we hope will happen in December, we'll request new data from 2009 through 2014 to add to our already collected 2004 through 2008 data. The new data will be coming from, we hope will be coming from newborn screening, Medicaid, and vital records, with annual requests for new data after that. And at the time we receive IRB approval, we will also begin approaching our former clinical partners about updated case reports and looking for new clinical partners who may want to work with us on this project. For phase 2, we plan to accomplish during year 2 of the project, which we plan to accomplish during year 2 of the project, and is really kind of the most ambitious portion of this. And that'll be starting next spring. We'll be focusing on the database development and linkage. We will refine our previously developed linkage processes and create a new linked and deduplicated data set that we hope will be more flexible than our previous efforts, flexible enough to be revised over time as new data come in and understanding of the data grows. We will be requesting IRB approval for data collection from the clinical partners and establishing contracts and data use agreements with them, and we know that that can be the most time-consuming part of this work, and hope to be able to achieve that during year 2. And then finally, we hope to be able to collect data, a minimal amount of data on new cases from 2009 to 2014 from those clinical partners. Phase 3 has far fewer bullet points, but is really the most important part of the work. We'll continue to integrate new data annually and continue to refine our linkage methods, but the focus now will be on doing useful things with the data. So we'll be continuing collaboration and education that's already begun, but also doing formal analyses of the data and dissemination via journal articles, fact sheets, presentations, and anything else that we can think of. So it's challenging and engaging, and as Mary said, it's fun to do all this technical stuff, but the harder thing for many surveillance efforts is always figuring out how to use the data that you've collected to best serve those in need. So we asked ourselves, how can we use population-based information on people with sickle cell disease to change care, outcomes, and quality of life for the better? We've already begun establishing relationships among local, state, and federal partners, and I'll talk about those in a minute. And I'll describe some of the conversations that Mary and I have had this summer. And Faith is already engaged with a number of potential partners across the state with the goal of supporting their efforts with our data as well as any other help that we can provide. We know that we need to focus our attention on healthcare disparities, challenges for patients and their providers, and lack of access to care. And we intend to answer specific questions that are important and have a high impact and are a good use of these data. So in order to figure out what those questions should be, Mary and I thought it would be best to ask as many smart, experienced people as possible. So we had a couple of road trips. Over 2 different weeks this summer, we visited the San Francisco Bay Area, Los Angeles, Orange County, Bethesda, Silver Spring, and Baltimore. We talked to people living with sickle cell. We talked with their healthcare providers, their support systems, and the community-based organizations who work with them. We talked with researchers, social workers, state and federal agencies, national healthcare organizations, and people who are working on new treatments. These were really packed trips with lots of information shared. That's Mary up on top and me at the bottom for those of you who haven't met us. We learned an enormous amount during our travels, even though both Mary and I have been involved in sickle cell surveillance for a number of years. There was lots to learn. And the biggest challenge at the end really was to try and figure out which of the scores of ideas and hours of input should be our primary areas of focus in the first few years of work. So here is a list of all the different groups and a few individuals that we spoke with. We were and continue to be very grateful for all the input we received from these very caring and enthusiastic and very supportive stakeholders, as Mary said. I'll go over the primary areas of focus we discussed with all these groups that struck the right balance between being useful, filling gaps in knowledge, and appropriate for the data that we have. So I'll start with the geography of sickle cell in California. We'd like to know where people with sickle cell disease are living and how far away, more importantly, are quality care and other services from where they're located. We can use the mapping expertise that the tracking program has to drill down and look at access by public transit as well as by physical distance, or as the crow flies. We'd like to quantify whether and to what extent patients in some areas are denied access to care based on where they live. We'd like to provide information to our partners to help them with outreach efforts, grant applications, figuring out where to put new clinics or support groups. In addition to figuring out where patients are by region, we will be able to see where knowledgeable providers are and may be able to support efforts happening in the state to connect providers with patients in need. Here in the tracking program, we already know a lot about how where a person lives impacts health. We'd like to learn how where people live and what they're exposed to have an impact on the health of those with sickle cell. So we wonder if people living with this disease are more likely to be exposed to harmful substances than the general population, or if harmful substances create extra health problems for them. For this work, we'll be providing reports and fact sheets with these data to support decision-making and policy change. So transition, for those who are familiar with genetic illness and sickle cell disease in particular, you know that transition from pediatric to adult healthcare is an extremely challenging time, and that many young people are unable to connect with a knowledgeable healthcare provider. So this is coupled with a significant increase in the symptoms and complications of the disease during the teen and young adult years. And we'd like to be able to add as much to the understanding of what is happening outside of comprehensive care centers as possible. So we wonder where are patients seen and when, in particular if they're outside of a medical home. Our initial analyses suggest that the majority of young adult healthcare encounters for sickle cell are in the emergency department. We'd like to verify and quantify that. We also wonder what happens to young adults in their adult care settings. What are the differences in outcomes between people who receive care in the emergency or primary care settings versus in a medical home? What conditions in childhood predict poor young adult outcomes like high emergency room utilization, severe pain crises, or mortality? And how do these conditions change adult health status? It's really powerful having longitudinal data because it allows us to be able to look back in time and come up with some of those predictors that we may be able to focus on for prevention. We expect that the results of these analyses will be distributed via peer-reviewed publications, but as with other areas of focus, we'll also be doing presentations, fact sheets, and reports. While the proportion of Hispanic and Latino babies born with sickle cell disease remains constant in the state, we know that the demographics of this disease are changing. Hispanic births are increasing in the state overall, and that changes the numbers and proportion of new sickle cell disease cases by race and ethnicity. We also know that there are, especially in the San Diego area and throughout Southern California, an increasing number of immigrant cases. Conversations with providers suggest that non-Black immigrants may have a hard time obtaining a diagnosis and a harder time with access to care than even those who were born in the United States. So we'd like to be able to quantify and describe these changes and challenges, and we'd also like to be able to determine whether there are important differences between disease severity and complications among different race and ethnic groups, as some literature has suggested recently. So the results of these analyses would come out as educational materials for providers who may be seeing these patients, as well as data to support outreach. Little is known about adults over age 45 living with sickle cell, especially those not seen in comprehensive care centers, which in California we know is the majority. We'd like to know where they are going for health care, the types of settings and providers, and what are the specific complications of sickle cell that they're experiencing and at what age. We know that people with sickle cell are not immune from the chronic diseases that affect the general population. Are cancer, diabetes, and other routine screenings for those middle-aged and older happening in this population? The mortality rate for nearly all age groups in sickle cell disease is higher than that for the general population. and we wonder what the predictors of death are among older adults. Will be some of the information around mortality and mortality rates in California will be coming out in the paper that I mentioned earlier. And we expect the results of these types of analyses to be published, and we will, of course, also offer data and education to support other efforts to change outcomes. And finally, our last area of focus is high emergency room utilization patterns. A lot has been written about and theorized about high ED utilization among adults with sickle cell disease. With longitudinal data, again, it's very powerful. We're able to look at patterns of utilization by individual over time. And in most cases, we see other pieces of relevant information as well, such as outpatient visits and health history. This allows us to understand why high utilization is happening and what can be done to prevent it. The majority of such utilization is for pain in the data that we're seeing, but we are also seeing many other primary diagnoses as well. So we'd like to know what factors start and stop periods of high utilization, and are there particular events, complications, or treatments that might change the pattern? We wonder, how does what happens after the emergency room visit change subsequent utilization? Does admission prevent future ED visits? And what about outpatient follow-up treatment? And finally, how does the facility type and geography impact utilization? So data from these analyses might be fact sheets or other materials to help facility level education efforts, data to support efforts to change Medicaid or county level policy, and journal articles. So that was a lot. We will be releasing a report later this week. It just got CDC approval to be released on Friday afternoon, and we need to format it and clean it up a little bit. The report that will detail all these target areas and the work that's already been done, the specific knowledge gaps that we see, and our plans for addressing them. As you might expect with the diversity and number of people that Mary and I spoke with, there are actually many areas of interest that weren't included in these 5 target areas. All of them are addressed in the report, including information needs that we see and the reason that they may be challenging to do with the type of data that we're collecting. I'll touch on a couple of them here, areas of high interest that we did not feel that we could adequately address or had the resources to address. Healthcare quality for people with sickle cell disease is challenging for a number of reasons to do with the data that we have. Costs of care, also we have partial data on costs but not complete data on costs, and we feel like there are other sources of data that would better address this. Narcotic use and pain management is something of enormous interest to anyone who researches or sets policy for the sickle cell disease population, and there was a lot of interest in this, and we just felt overall, after lots of input, that the resources needed to address this really were beyond the scope of this project, that really it needed a whole project devoted to it. Transfusions are an area that we looked at quite a bit during the RUSH and FRESH projects. They're very challenging to look at in administrative data for a number of reasons. And the CDC is currently funding work in transfusion monitoring and complications in Georgia and just recently beginning in California. And we hope to support that work, but will not make it a direct target for these data. Quality of life and burden of disease on the people living with sickle cell, in addition to the cost, is very challenging to do with administrative data. It's probably better done at a clinic level or by community-based organizations. Preventative treatments and screening will be something that we are addressing, I think, as part of some of the other target areas. HRSA currently has a major grant to look at hydroxyurea use, and we are partnering with them to support this effort in California. Rates of complications also have been addressed, I think, fairly well at a clinical level using clinical data, and we can do some of that work in the target areas that we're talking about. Fertility and pregnancy are very challenging with administrative data. We have information on what happens at the moment of birth, but very scant information on what happens during pregnancy. And finally, sickle cell trait, which is of particular interest to many and a major gap in understanding. The data that we're using for this project don't address sickle cell trait, but we are trying to find additional funding to be able to look at newborn screening data on sickle cell trait and outcomes. So watch for that in the future. There are several other large-scale federal projects underway to collect data to understand the impact of sickle cell, and we wanted to just touch on the overlap, the comparisons and contrast between them. The HRSA-funded Get Connected project is a patient-powered registry that works with community-based organizations to collect basic demographic information on patients after gaining their consent. It also creates a secure location for patients' medical history, and we hope to support their efforts in California by providing geographic and facility data to indicate where patients not currently in care are for outreach efforts. And we've already been in conversation both at the state and national levels about collaboration. The National Heart, Lung, and Blood Institute Sickle Cell Disease Implementation Consortium is currently accepting proposals. It's in the RFA stage. Clinical sites for that program will participate in the development of a sickle cell disease registry in collaboration with the Data Coordinating Center and the NHLBI. This registry development effort is geographically based and will include outreach to underserved adolescent and young adult populations. And we don't know yet who will be funded, but assuming that there are California grantees, we would welcome opportunities to work with partners here and think that, again, we can provide data to help target the outreach. We hope that down the road there will be data connection and synergy at state and federal levels and across each of the federal partners with the strengths that they bring. For now, we feel like the gap that we're filling with this project is to document what's happening for those who aren't yet in high quality care and to provide a baseline for population-based surveillance beginning all the way back in 2004 so that we can view changes as new programs, care guidelines, and treatments come into play. So the report that this presentation is based on, as I said, will be available within a couple of days. We'll be sending a follow-up email to everyone who registered for this webinar to distribute it. We will be holding more webinars. We intend to do quarterly webinars in which we hear from guest speakers about their work in areas that relate to what's happening for people living with sickle cell disease, and we welcome suggestions for those speakers. There will be a survey that pops up at the end of this webinar, and one of the questions that we'll ask you is about suggestions. And at each of those webinars, we'll also give a brief status update for this project. So look for the next webinar early in 2016. You can look for updates on the CDC's website, which is here, as well as the California Sickle Cell Resources website. Both of these will be updated with information about this project shortly. And the very best way to keep track of us is via the California Sickle Cell Resources Facebook page, which Faith is a primary contributor to. So I will stop talking, and we will open the floor to questions. So please submit your question through the chat box in the webinar control bar, or you can raise your hand in the webinar sidebar and we'll unmute your line. Thanks. Okay, we're struggling with reading the questions in the box. We apologize. Can you make that box a little smaller? Okay. Yes, we are willing to disseminate the slides, and we will make those available. We will also make the recording of the presentation available to all who are registered. Yes, we are in touch with the SCDAA, both at the local and national levels, and they were one of the groups that we spoke with in Baltimore as well as here in California. Yes, so questions about quality of life and being labeled as a drug seeker, I think, are particularly important for us to answer with our emergency room data, and that's one of the interesting things that we feel has come out of the work so far, and we're actually, Mary and I are working on a publication about this. So we see that people who go through high utilization in the emergency room it is a sporadic thing. It's not that one person is a high ED utilizer for a very long period of time, and we feel like understanding this in particular in the emergency room setting will help that reputation somewhat. So look forward to something being published on that soon, and then more work being done on that as well. And I apologize how hard it is for us to see these questions, but we're working on it. So do we plan to examine cost of care? I went over that a little bit. It's very challenging to do with these data. How did we validate the case definition? So we validated the case definitions by using known cases. And there's actually a whole report that's written on this that we're also happy to disseminate if you send me an email. And oh, look at you. Yay! Okay, now we can see the question. Gosh, so many questions. Okay, so PCORI is making a registry through PCORnet. We did just hear about that and are excited to know about it, and we'll be talking with them about how to collaborate. I'm going to let Mary answer how other states can participate in just a moment. A question about racial diversity in sickle cell disease, particularly the Hispanic patients. Again, this is going to be a target area for us. Will we have data on cultural barriers to hydroxyurea use? That's a wonderful question, and it's not one that we've thought about yet. So that may be a little bit hard to do with administrative level data, but we may be able to partner with others, particularly in Southern California, to address that question. Do we know when the deadline is for the NHLBI grant? I believe the deadline for that grant is this week or possibly Monday. It's very, very soon. There's a question about whether we will have data by sickle cell disease genotype. So when we have confirmed cases that we know about through newborn screening or through our clinical partners, we do have genotype information. We have not counted on the ICD-9 coding that is available that points to genotype in administrative-only data. We believe that has a lot of problems with it. So we've tended to address all of our non-confirmed cases as just unknown, and that may be something that we can explore going forward. It may be that coding gets better with the new ICD-10 diagnostic work, and it may be that as we follow people over a longer period of time, we have a clearer picture because they may have been seen in clinical settings. We have a clearer picture of what their genotype is. Are we aware of any other countries' efforts to do similar work? And could we comment on their relative strengths and weaknesses? Again, I'm going to leave that one for Mary. I'm going to come back to her questions in just a moment. I'm not going to answer questions about the incidence rate right now. We do have some great fact sheets about that we can share. We will be collecting some data about hydroxyurea utilization, although that's not a focus of this work because of so much other work going on around that right now with the HRSA grant. Okay, and I am going to stop answering questions and ask Mary to answer a couple. Mary, are you on the line?
Yes, I'm here.
Okay, can you answer the questions about how other states might get involved and about international efforts?
Sure. So there's a couple of parts to the answers of each of those. Regarding other states getting involved, I would say that, as I spoke about at the beginning of the talk, we are hoping to contact and partner up with additional funding partners. If that is the case, that we are able to do so through the CDC Foundation, we are certainly going to be using those funds to partner with additional states. So really, right now, it's a question of resources. However, I know that other states also have smaller scale projects that they are either beginning or are in the process of continuing. And as always, if any of those additional states would like to get in touch with CDC, I am always more than happy to provide a technical assistance for those projects as they get going. I'm more than happy to put those states in contact with other groups that have done similar type work and have had great success doing that so that they can learn. I would say, and again, this is resource dependent, we would love at some point to be able to put together some educational either webinars or symposia or just some other format to help other states learn the more technical aspects of what are being done with these data collection efforts. So yes, those are all areas that we would like to take part in. We would very much like to work with additional states. At this point, it's a matter of being able to identify funding sources to do that. So in regards to other countries, I am not aware of other countries that are doing sickle cell surveillance in the same way that we are, and by that I mean I don't know of other countries that are, for the most part, heavily relying on administrative data to collect their information. That being said, I know that there are large-scale efforts in other countries to follow patient populations and patient cohorts. I'm sure there are many more than these, but there have been numerous studies of cohorts in Jamaica that have been followed for a number of years. I know that Brazil has a large-scale effort of following babies who are identified through newborn screening. I know that there are several areas in African countries that are hoping to implement newborn screening and through that be able to follow those babies over a period of time. I know that in England, in the last few years, they've been able to put together a cohort of patients that they follow. But again, you know, the United States is quite unique in our healthcare system because so many people are insured by different groups and go to so many different healthcare providers, and that's not always the case in other countries. And so just to some aspects, they have a much easier time of being able to follow these patients because of the healthcare systems that are implemented. Once there's newborn screening or another screening program available to identify the patients, the actual follow-up is somewhat easier to some extent in other countries.
Thanks, and I'm going to throw another one at you. So there's a question of asking for an example of how surveillance has influenced public policy.
Sure. So although I am sure there may be examples in sickle cell disease, I'm going to go outside of sickle cell. So as you're probably aware, there are cancer registries that have been around that CDC has been working on for the last 30, 40, 50 years. And there's actually, and I usually have a slide about this, I didn't include it today, and I guess I should have, but you can go on the CDC website and look up their cancer registry, and you can actually click on different states and see how the surveillance efforts for cancer have led to actual policy changes within the state. So for example, things that range from greater coverage of screening in particular states that's covered by state-based programs to different programs for employees that are diagnosed with cancer and kind of the policy that surrounds their employment. So there really are a number of examples where surveillance efforts that are well funded, that are sustainable, that are carried out for a period of time truly do lead to great policy changes.
Okay, great. We have there, I'm just kind of boggled by how many questions there are and very appreciative. I'm not sure we're going to be able to get to all of them, but I am going to take a couple of hand-raised questions. So Diane Nugent, we're going to call on you. Whoops. We were going to call on you. She went away. All right. Diane, are you there? No, I apologize. And I was going to try and call on Daisy, but it doesn't look like her audio is open. Okay, so I'll go back to the written questions. So a really good question is, are local public health departments involved in this effort? I think that is really where a lot of stuff is happening right now, is at the county level in California, and we have a couple of city level local health departments as well. And that we worked some with a couple of the local health departments during the FRESH project, and that is an area that I think we would really like to expand on in this project. Many decisions are made at the county level, and I think being able to, what we learned in the past was that counties often don't know what's happening in their own county. They don't have access to the data that we have, and so to be able to provide them with data about what's happening in their own county at their own facilities with regard to sickle cell disease, especially the high impacted counties, I think could be really useful and a great partnership. Is there any intention of making the data that we're collecting available to other groups to conduct analyses? So we have to worry a lot about patient confidentiality, but that said, we have in the past made data available, aggregated data, or a very minimal de-identified data set available to researchers who have a specific research question that they'd like to ask. So we're happy to talk about that offline. Question about whether or not stroke will be of interest in addition to renal and cardiac outcomes in older adults. I think we'll be looking at all the diagnostic codes that we see to try and understand what's happening in that population, and certainly stroke would be one of the things that we're looking at. And Dr. Ivy suggests that we might want to work with the CMS to get more accurate data in a timely manner, and that is definitely a group that we have been in conversation with at multiple levels, both the regional level, the Center for Medicaid and Medicare Services, I think is the S, both at the regional and at the federal level. So, and then a question about a couple questions about the military data. So we don't believe that there are a lot of people with sickle cell disease serving in the military, but that it may be that there are family members who are impacted. And we believe that we're seeing those data, at least at the youngest age, in some of the comprehensive healthcare centers around the state. But that is an area that we need to explore more. So I think we're going to finish up the call. We really appreciate, and we're kind of overwhelmed by the number of questions, the interest, and hope that you'll stay in touch with us. As I said, we'll be sending out a follow-up email and welcome questions and comments and further dialogue. And you can look for our next quarterly webinar probably in January of next year. And we thank you all for your time and attention.